Welcome everyone. I think we'll make a start. Welcome to this high-performing primary care series from Northern Queensland PHN, and it's stream 1, so it's Continuous Quality Improvement and Practice Incentives Program, QI. This is the second one of 3 parts in this stream, and I'm Paresh Dawda. I'd like to start off with an acknowledgement to country. We acknowledge the Aboriginal and Torres Strait Islander peoples as the traditional owners of the lands and pay our respects to their culture, their people, and elders past, present, and future. So I'm just going to, before I move on, there's a couple of comments in the chat. So thanks, Janine, for checking in with everyone to see if you received your workbook and activities. The workbook and activities for all 3 parts of this stream are together. And so what you will have received last week will have today's slides and next week's slides in there, and the activities from there as well. Just a note from AGPAL about the slides and a copyright notice, which is a standard notice put on all our presentations with respect to copyright. So I'll just bring and draw your attention to that. I'm hoping that all of you who are here today were on the webinar last week as well. So this is a follow-on webinar from last week. And as I said, I'm Paresh Dawda. I'm a GP in Canberra, and I practice actively for about 50% of my working week. The other 50% is taken up by a whole bunch of various things. When you look at all the other things I do, I guess the golden thread around them, running through them, is passion for sort of patient-centered, person-centered care, quality improvement, and patient safety. So just a bit of context setting and background to what this stream is about. So it is the introduction to high performing primary care series. And I think, as I said last week, I like to think of it as higher performing, because I think we do have primary care, which is high performing already. So it's how we do better and can go to that sort of higher level, the next level of performance. And the program in the series is funded by the Northern Queensland Primary Health Network through the Commonwealth Government's PHN program. And thank you for the Northern Queensland PHN in supporting this initiative, which I think is great. The initiative does consist of a series of 4. So we're at point 1, the Continuous Quality Improvement and the PIP QI series. The second one is around the RICGP 5th standards. The third one's around population health and digital literacy. And the 4th one's around integrated care. So we're really starting off on the journey. And when you look at what this series is trying to do, it's really education and training. It's about capability building. So we can work towards achieving the quadruple aim in healthcare, and talk a little bit about what we mean by that. Embed a culture of continuous quality improvement. And we last week talked about the why that's important. Today we're going to talk a little bit about the what, and next part we'll talk about the how. It's really looking at how can we align all the other stuff that's going on in general practice and primary care at the moment, and really use that to embed that culture of quality within our organizations, within our practices. Is how we use technology to help us do that. How do we use data in an intelligent way, in a sensitive way, and how do we use technology also to help us with engagement. It's not about making our jobs harder, it's about making our jobs easier. So one of the thought processes behind it is what can we do to implement in a sustainable way, so we don't have to keep working harder and harder and feel like we're running faster and faster, not getting anywhere. It's really about taking a different approach. And it's about promoting integrated care in the region. So quite a lot of aims and objectives around this series to think about. So this first component on continuous quality improvement, as I said, is broken into three parts: the why, the what, and the how. Last week, we talked about the why. We talked about why we should focus on quality. We talked about the quadruple aim. So it's about improving patient outcomes, but it's also about improving experience for patients and experience for those of us working in the health system. And it's about doing it in a financially sustainable way. So achieving all those four things together constitutes a quadruple aim. It's about a journey, and it's about a sort of relentless approach to continuously looking at improving. And if we do that, if we make quality improvement part of our daily job, then we accelerate and we get to a place where we can be higher performing and achieve that quadruple aim, and some, so surpass it. We can start innovating. And we talked about aligning the sort of goals that we might be having in our practice with what else is going on around us and in the external environment and the rest of the system. So we really made the case for the why last week. Today, we're going to focus on the what. So we're going to talk about quality management systems. We're going to talk about model for improvement. We're going to talk about the PIP QI and an implementation plan. And next week, we'll talk about the how. So how do we get there? How do we use quality improvement tools to help us get to achieve the what? So stuff we're going to be talking about today. I'm going to just pause there and invite some comments and feedback from the last session. So we can do this in one of two ways. I'm more than happy for you to take yourself off mute and talk to your thoughts and reflections from last week. If you prefer to type it in the chat box, I'm more than happy for you to do that as well. So over to you. Stunned silence. Okay. If there's no feedback, or if you have thoughts that come to your mind as we go on, then please feel free to type them in the chat room, or at any point take yourself off mute, and I'm more than happy to be interrupted. I kind of see this very much as conversations. So yeah, please feel free to stop me at any time and either clarify any content we're talking about or share your thoughts and reflections. The more you engage with the conversation, I think the more you'll get out of it. So please feel free to do that. So when we're looking at this series and what are we trying to get out of the learning outcomes from the session, today we're really looking at that CQI principle and how that can help us achieve whatever our practice goals might be, but also assist with PIP QI. We're going to talk about a quality management system. So quality doesn't just happen, it needs to be managed. And what does a quality management system look like? We're going to think about the model for improvement and how we conduct an authentic PDSA cycle with the fidelity with which it's designed. And so that's something we're going to talk a fair bit about next week. And next week, we're also going to talk about a system for measurement for improvement. So, you know, the concept being, if you can't measure it, you can't improve it. So how do you measure it? How do you measure it in an evidence-based way? And then how do you translate that learning you're getting from the measurement into improvements through using something like a model for improvement? And we're going to talk about the PIP QI, the eligibility and requirements. And one of the activities in your books is about developing an implementation plan for your practice. So we'll kind of touch on that, and it's perhaps some homework for you to be thinking about with respect to that. So let's start to talk about the what. As we go through this morning in the next couple of hours, we'll talk about what a quality management system is. We'll talk about why we reliably fail and what do we need to do to address this. So I'm very keen on the sort of concept of human-centered design. So I'll ask you all to just perhaps think about, you know, how many of you have a smartphone, particularly something like an iPhone, and how many of you have had specific training on it, and how many of you haven't, but you can still get around the functions of using the phone. And when we often do that, what we find is when something's been designed with the human in mind, it just makes it easier to do the right thing. We've thought about the human factors. It allows us to make it easy to do the right thing and hard to do the wrong thing. And even if we do the wrong thing, it sort of captures it and stops it before it becomes a problem. The question is, how do we use those principles in the way we design care processes and care pathways to make it easier to do the right thing, harder to do the wrong thing? So we'll talk about some thoughts behind that, and sort of defining the problem we're trying to fix, and the model for improvement, and the PIP QI, as I said earlier. So that's kind of the focus for the next couple of hours. You have got some reflection sheets, and so as we talk about the what today, what I'd like you to do and consider is the so what. Whatever I talk about, whatever we discuss, what does that mean for you in your practice, in your organization? That's what I mean by the so what. So it's contextualizing that information for you. Once you've done that contextualization, we can then translate that into the now what. So as a result of what you've heard and understanding your context and what it means in your context, what will you now do differently as a result of what you've learned today? And going through that sort of reflective process is what's going to make the difference in terms of implementing your learnings from the webinar. So strongly encourage you to think about the what, the so what, and the now what. And you have got a reflection sheet with those headings. So, you know, I'd encourage you to perhaps look at that and compile that as we go along. So let's start with thinking about what we mean by quality management system. Just sort of pause and ask you again, and again, please feel free to come off mute or use the chat box. Does anyone have a quality management system in their practice? In terms of using the technology, the other thing you can do is, if you look at the participants list, there's a yes button there and a no button there. So you could actually just use the yes button or the no button to tell me whether you have a quality management system in the practice. Yep, so we've got a yes from Serena. Anyone else? So we've got a yes from Jody. Jody, Serena, could I ask you if you feel comfortable to perhaps share with us what your quality management system looks like? So Serena says you've got a PNP manual, so policy and procedures manual. How about you, Jody? Okay, so Serena, thanks for adding to that. So the PNP manual describes what's expected and how you review adverse events or suggestions. Great. And Jody's, you say you've got a register for quality improvement. Can I ask Jody, and I'm just wondering, would you mind if we took you off mute? Are you able to talk to it, to either Serena or Jody?
Hi. What did you want to ask about or discuss?
If you perhaps just tell us a bit more about your PNP manual and what's in there and how you use it.
Okay, so when we took over the clinic, it was a just a document that got looked at every 3 years when accreditation came around, and we decided to make it more of a living document. So we upgraded, and we've already done our 5th. I think we might have been one of the first transitions to the 5th standards. So then what we do is when there is a suggestion for an improvement, I hope this is what you're sort of talking about, we do I still call it the plan, do, check, act cycle, but in the manual it's called something else. So we look at, rather than making a big jump and looking at quality and how we might change it, we do lots of little steps for a couple of reasons. One, sometimes it's very onerous for staff to go, oh God, now we've got to do this. So small manageable steps and just keep reviewing that progress. And that's part of that's actually in our manual, those steps. So that means that I don't have to run it all the time, or the practice manager doesn't have to run it all the time. So let's say the nurses say, some nursing thing needs checking, the way we do recalls or immunisations, and we do a little cycle for that. Okay. No, we make them do it. We do it together.
Great. Okay, so you've got sort of an approach. So as a practice, you adopted a way of improving. You've bringing the team on, and everyone's sort of getting involved in the improvement.
Yeah, and we do those at our staff meetings, and with our staff meetings, we do things like a privacy audit. So someone randomly goes around and says, okay, at the end of the day, is there, let's say, patient documents face up where the cleaners might see it, or is there, that's a big one actually, that doesn't happen anymore, but just things like that to sort of keep you moving forward rather than thinking, oh, we've just done our accreditation, we don't have to worry about doing anything for the next 3 years.
Yeah. So what you're describing there, for example, with that sort of compliance check around privacy, is you're describing a component that's sometimes referred to as quality control. So you've got a policy and procedure around it, and then you're sort of doing a compliance check. It's just an internal check to see whether you're compliant with that policy and procedure.
Mm.
Yeah. So that's a sort of a quality control component within the quality management system. So that's great. Thank you so much, Serena, for sharing that. Anyone else want to share? We might then move on. And when I think about quality improvement and quality in general, I guess one of the gurus of this is a guy called Edward Deming, who in the sort of Japanese car industry post-war did a lot of the learning there. And he came up with what's sometimes called the Deming system of profound knowledge. And that's really got 4 things in it. So it's really got in there that first of all, we've got to appreciate that whatever we do is a system. It's a combination of different components that are interdependent and rely on one another. But what we really work in is a system. And so I'll kind of show you a bit later on a slide what such a system might look like in general practice. The second thing Deming said is we've got to have knowledge about variation. So when things go up and down, things we're measuring go up and down, we've got to really understand, is that up or down, a significant up or down, and what's contributing to that variation. And that's where some of the thinking around measurements for improvement comes from. So some of the indicators that are in QI PIP, for example, partly comes from that. But if we really want to take it to its fullest, we've got to really think about how we can understand variation. So we touch on that in next week's webinar. That's measurement for improvement. The third thing Deming talks about is knowledge of psychology. So if we really want to change things and change behavior and get people in a place where they're doing things differently, we really got to understand human psychology and how to implement change that takes account of that human psychology. And so that's where, I guess, when I was talking earlier about, you know, the smartphone example and human-centered design, that's where that comes from, you know. So if we understand human behavior, human psychology, we can then start to design interventions to help us improve quality in a human-centered way, which means we're not constantly saying to people, please put that diabetes code in, and constantly reminding people to put the allergies in and ask patients to put the allergies in, or ask patients about their allergies so we can put them in the right box in best practice or medical director or whatever system we're using. So that's sort of the third component, the knowledge of psychology. And then the fourth component is theory of knowledge. And what Deming means by that is whatever change we make in our system, we've got to really appreciate that that change will work in a different way in our practice as it does in another practice. So we can't just take an idea from there or over there and plug it into our practice, because our practice is a unique system with a combination of people that would perhaps behave differently. And so what we really got to do is test that out in our system and build the knowledge of how things work in our system. I think when Serena's talking about PDCA cycles or PDSA cycles, that's where that, you know, where PDSAs really lend themselves is about developing this theory of knowledge, right? So I think Serena was saying, you know, you make it really small, you make it sort of bite-sized, and you test out an idea and see whether it works or not. What you're actually doing is you're developing knowledge around what's working in your system and what's not working in your system. And I think that's really a fundamental concept in quality improvement, which is why I sort of wanted to emphasize it. I'm just going to pause there because I think, Jodie, you had some trouble turning your microphone on. Did you want to add to anything we'd said, Jodie?
I was just going to tell you about our improvement register. So
yes, please. Yeah.
Yeah. Okay. So we've just got the reason for change and the outcome goal sort, the relevant standard, if there's a standard that it relates to, the process for change, the success measure, the time frame completion date, and then progress notes on the change that happened, like the result from the change, if it was successful or not.
Yeah. Great. And how would you, who tell us how that's operationalized? Who manages that register? How often do you look at it? When do you look at it? What format do you look at it in? Do you look at it in a meeting or a huddle? Or tell us a bit more about how you operationalize it.
Okay, so it's like a living document, and if I get feedback from, say, reception, like one of the things in here is that all electronic information received is directly uploaded to the medical director holding file with the assigned doctor to minimise confusion, because some doctors wanted the faxes printed and then scanned, others wanted it scanned directly to the holding file, and so it was getting really messy, and reception asked if we could have a blanket process for all the doctors. Mm-hmm. So we put that to the doctors and they agreed that it would all go to the holding file to limit, to remove the confusion. And so now it all goes straight to the holding file and everyone knows where it is. And if the doctor needs to action it, then they print it, write down anything that needs to be done, and then give it back to reception and they action it and then rescan it. So that's okay. Just one thing.
Okay, great. And can I just ask Jodie, in terms of getting agreement from all the doctors around it going into a holding file, how was that process done?
So I think from memory, because this is back from last year, I think from memory I asked the doctors, but the doctors also have a meeting every Tuesday at the end of the month after 5 o'clock. So if I've got things for them or reception have questions or would like to change something, it's put to the practice principal and he'll bring it up at the meeting and then he lets us know of the outcome.
Okay, great. So you sort of engage them in that discussion, discussion and decision making. Yes,
definitely. And then it's the information's fed back to whoever's requested the change.
Yeah, fabulous.
And implemented.
And Serena's made a comment on the chat that it's great that you're relating the improvement back to a standard.
Yeah.
Have you found that useful as a way of getting leverage or demonstrating when accreditation comes around that you're embedding QI?
Yes, definitely.
Yeah. Because
there's different standards. There's another one like the vaccine management. We made a change there and put in clever loggers where they, obviously manage the temperatures all the time.
Yeah.
So that relates to vaccine management. So and just like recently with COVID, we got bollards put up. So for social distancing and for the pandemic, that relates to that category.
Great. Okay. That's really good. Thank you, Jodie, for sharing that.
That's okay.
So, you know, when we look at what Deming really talks about, and I think what Serena and Jodie have articulated in their practice systems, a lot of it's about learning, right? So one of the other concepts when we're thinking about quality improvement systems is this kind of concept of learning. Now, we often talk about triple loop learning, and I'll just maybe talk you through a completely non-health example of this, but I think it's useful. So you're sitting in the room, right? And you've got that room has a degree of comfort in it. Often temperature's the issue. So one of the things you could do is you could say, you know, if 18 degrees centigrade is a comfortable temperature in the room, we're going to have a thermostat in the room, and we're going to measure to see whether it's 18 degrees centigrade. And if it's not, we're going to have an intervention. So if it's lower than 18 degrees centigrade, we're going to put the heating on. If it's higher than 18 degrees centigrade, we're going to put the cooling on to bring it back down to 18. That's described as single loop learning. You know, we've made a decision that 18 degrees is the temperature, and we've got a measurement system in place, asking the question, are we doing things right? You know, a lot of quality improvement measures in healthcare are what we call single loop indicators. They're like measuring the temperature in the room. Have we got allergies recorded? What proportion of patients have got allergies recorded? What proportion of patients have got their smoking status recorded? What proportion of our eligible population has had cervical screening done? What proportion of our diabetics have had a HbA1c done? What proportion of our diabetics have a HbA1c below a certain target? They're single loop indicators, and there's nothing wrong with single loop indicators. We need them as part of a quality management system. But sometimes we need a second loop, right? The second loop is really around, are we doing the right things? So, you know, let's come back to that room temperature example. And is 18 degrees centigrade the right thing to be doing and measuring? Why is it 18? Why isn't it 19? You know, why isn't it 18.5? And we often have conversations like that in healthcare, don't we? But we don't necessarily capture them or think about them as a second loop of learning. So in my practice, for example, I do a lot of, so our practice is an outreach practice, and we do a lot of people with complex and chronic conditions who can't get it into general practice. So it's essentially a visiting service, a lot of residential aged care, a lot of palliative care. Measuring the HbA1c in our diabetics, yeah, we can do that. It's a single loop indicator. The majority of them won't be to target. You know, that's so 7% HbA1c is not right for our population. So our second loop of learning is really having some really detailed conversations with our clinicians about our practice cohort, the type of people we look after, and really thinking about what is the right quality indicator for the patients we look after. And yes, we can do single loop indicators, but they're probably not the right one. We can then go back to that temperature example, and we can have the discussion around whether it's 18 degrees is the right temperature or not, and do that second loop learning. But from that conversation, we might actually turn around and say, well, you know what? Is measuring temperature the right thing to do at all? Should we be asking all the individuals in the room how comfortable they feel in the room? Is that the right measure? You know, so that comes into that third question around how do we decide what is right and the context. So in our practice with that older population, we've actually decided what the right thing to do for our cohort of people is maybe focus a measurement on a patient-reported outcome measure. So we use a validated questionnaire called the SF36, the short form 36, which really is asking people about their health, how their health compares this year compared to last year, emotional well-being, physical functioning, pain, carers. So it's you know, for our population, we've kind of going through that first loop and then having discussions about the second loop has taken us to the third loop, which is that in our context, actually we probably need to be measuring things in a different way. So the triple loop learning, I find a very useful construct to think about. Are we doing things right? Are we doing the right things? And then how do we decide what is right? And I think in, you know, Jodie's example, the discussion with the doctors in the context, for example, with that management of paper flow, is a good example of really going through certain elements of that triple loop learning and thinking about that. So again, I'm going to just pause and ask you to describe the organization of your practice. And if I asked you that, I'm guessing most of you will describe the structure of your organization in some sort of hierarchical chart, right? So you've got the practice owners maybe at the top, and then coming down from that might be the practice manager and the lead principal, and then coming down from that might be the reception staff, the nursing staff, and perhaps the contracted GPs. Would anyone describe the organization of the practice any differently, in a different way? Again, feel free to type in the chat box, use the yes, no buttons, or unmute yourself.
Hi, it's Emma from Sydney Street Medical. How are you going?
Hi, Emma.
Yeah, with our organisation, we have a practice principal, or one of the owners is a doctor, and the other owner is myself, the practice manager. So we work alongside each other. So we actually, we have a clinical team, and then we have the more administrative team, which we both lead, but we all infiltrate into both areas. So it's rather an organic type practice where we sort of like, we streamline together, but we do they'll come to either of us, but predominantly to myself. So it's not a rigid structure, it's more of a organic structure where we can support each other. In regards to direction, as in who they report to for certain things, the clinical things predominantly does go to the doctor, but it's typically they all come to me because the doctor's usually busy, but then we actually work together and talk amongst it between patients, etc. So it's a little bit different than the usual rigid structure, but it works well.
Great, thanks for sharing that. Anyone else? So if we start to think about systems thinking, and if we were to sort of apply that systems thinking into, how we would describe our practice and the organization of our practice, we could think about it in a different way. And what this diagram does is it shows how we could think about it in a different way. And you'll see there's a little bit of overlap. But what I'd ask you to do is maybe just concentrate on the core process, that box in the middle, the yellow boxes. And so if you think about the journey of the patient through the practice, it often looks like that, doesn't it? There's this patient access, and we have processes around patient access, whether it's phoning through or coming in, and interpreters, if we need to use interpreters, would fit into this box. Disability access, wheelchair access would kind of fit into this box as well. But patients access our services, and we have various processes around how they do that. And then they receive the clinical care. And so we have various patient care processes that help us do that. We record and monitor the care that they receive. And then we have a sort of payment process when they exit the practice. Maybe as part of our core processes, we need to think about how we manage relationships as well. Because we can't really work in isolation as a practice, can we? We've of course got our patients and how we manage the relationships with those patients, but we've got the rest of the services out there in the neighborhood, be it private allied health or community services or hospital services or pharmacies. And with some of them, we have closer working than we do with others. So how, a core process is around how we perhaps manage some of those relationships as well. Now, we can't do those core processes without having some support processes. So the support processes are the ones at the bottom. They're the things around managing people, our recruitment, retention processes, induction processes, training processes, continuous development processes around this, but also how we engage members of our team in various things we do. There's the information management and technology process, the computer systems, the phone systems, how we manage all of that. There's the management of finances and tracking of that as a process. And then we've got facilities that we need to manage. That's the premises, but also the equipment and the infrastructure within the practice, so we can deliver the care that we designed to deliver. So we have a bunch of core processes. Those core processes need to be supported by our support processes. And then if you just think back to the triple loop learning slide I talked about earlier, and what Deming talks about with the appreciation of a system, what we really need is some high-level processes as well. And in those high-level processes, we need a sort of feedback system, right? So I'll draw your attention to the box on the right at the top, the business process management. So that's really a process around capturing that data, the feedback loops from the triple loop learning, where whether it's our number of our patients with allergies, number of our patients with diabetes who had HbA1c done, all those dashboard indicators. It could even be things about our staff, and how happy do our staff feel in the practice, what's working for them, what's not working for them. All of that could feed into that sort of business process management. A bit like, I think your register, Jody, you described, may fit into that sort of business process management up at the top there. That then feeds into the practice's mission, vision, strategy. Learning from that might lead to some new products, new services you might develop. And the learning from that might actually translate into some quality improvement in your core processes so you can improve. So that's a really different way of looking at a practice, and really thinking about the practice as a system, as opposed to a hierarchical organization chart, which is what's often used. And if you take this a step further, and we can provide you a reference with about this, but you can take this a step further and you can actually assign teams to say, you know, these people are part of the patient care team, these people are part of the access team, these people are part of the recording and monitoring team. So in a similar way to what Serena was talking about earlier around that sort of distributed quality improvement, you can sort of put people in charge of certain key processes, and they're then responsible for the improvement of those processes as well. So I just wanted to really give you a sense of when Deming talks about appreciation of a system, how we could translate that into a systems look at our practices. When we go back to quality improvement, you know, and we've got this sort of systems approach, we can start to think about, if we've got these feedback loops set up within the organization of our practice, the way we organize the practice, we can start to think about what we can change and what we should improve. When we come back to quality improvement and thinking about that sort of systems approach to quality improvement, what the data, you know, what the evidence tells us in this space is there's a whole bunch of things we need to be thinking about. It's a principle based approach, so it's thinking about service and customer focus. And I did a webinar last week for Consumers Health Forum, and I kind of talked about maybe we need to stop thinking of ourselves as a service industry, but maybe think of ourselves as an experience industry, to really sharpen that focus on the consumers that receive our services, our recipients of our services. Often a lot of this needs leadership to engage, support, and influence. So there's some of the principles we need to use around that alignment piece. So I think, Jodie, in your example again of aligning the QI you do with the standard, you're really getting some alignment of vision and goals, which is helpful. In some practices or some organizations, they'll map that back to their vision, the values, and the mission as well. A systems and process focus, and that's sort of just highlighting what Deming said there. That constant feedback loop, the business process management we talked about in the previous slide. So with regular data collection and analysis, PDSAs, so we're constantly looking at improving. In a paper which really looks at high value, high performing healthcare organizations, to look at what the 4 habits were of those organizations. One of them was measurement and oversight. And a lot of these high performing organizations had not 10 indicators they were looking at for quality. They were looking at 300 indicators in a really balanced sort of dashboard of what was going on in their practice in the healthcare service, and constantly looking at that to improve with. Education and development are part of that. Culture is really important, and culture is really the way we do things, the way we do business, if we think about it from a financial perspective. But you know, just the way we organize ourselves and the way we do things is often described as culture. And really thinking about a quality management system as being quality planning, quality control and quality assurance, and quality improvement. So there's 4 components. And last week, and my apologies, I forgot who told us about the reference from Amar Shah in the BMJ. I think that was shared with you last week. That reference really is talking to those 4 components of a quality system, quality management system. To really summarize this section, the King's Fund in the UK looked at a whole bunch of healthcare organizations and looked at the 5 attributes of quality within healthcare organizations and came up with these 5. So again, reinforcing what we said in the previous slide about patient-centeredness, it's client and community-centeredness, leadership, culture for CQIs, embedding it in everything we do, involving the team, and the team's a big part of this, and then thinking about our practice, our healthcare organization as a system. These 5 things is really where intrinsic quality comes from in high-performing health organizations. Just going to pause there before we move on to the next section to talk about today and ask whether there's any questions at this stage. So no from Serena. Anyone else? Any questions? I'll wait 30 seconds. Okay, let's move on if there's no questions. So we've talked about quality management system. I guess the next thing we've got to think about is understanding the problem. What are we trying to improve and where could we make a change? There's a few tools that are really useful in helping us think about this. So I'm going to outline the tools and then we're going to sort of talk about developing reliable processes really. So has anyone come across a fishbone diagram? It's sometimes called an Ishikawa's diagram. So that's a yes from Serena. Anyone else? Emma, yeah? Janine, yes? So some of you have come across this, which is great. Any examples of use in practice where you found it particularly helpful? Okay, so after an adverse event, Serena, yeah. So that's where I guess a lot of the Fishbone Ishikawa comes from in its application in healthcare. It's just around root cause analysis. So there's an adverse event. People following an adverse event ask the question why, and it's called the 5 whys. So they ask the question why, and why. And the idea is whatever problem you're dealing with, whatever adverse event you're dealing with, you want to try and get to the root cause of it rather than sort of just dealing with the problem superficially. And so people often combine the 5 whys with a fishbone diagram to then sort of start thinking about what are the problems that contribute, what are the issues that contribute to the problem, and that really try and drill it down. Often those problems, those issues can be categorized around environment, methods, equipment, and people. I'll show you something else a little bit later, which I find really useful in terms of thinking about a root cause type of approach. But a fishbone diagram is really useful because what we often find is we don't deal with the root causes. We deal with the problem superficially, and then we find the same issue keeps happening because we haven't really addressed the complexity and what underlies that issue. So I just wanted to highlight that tool, and again, we can give you references around how to use this. The next tool I really wanted to highlight was process mapping. Has anyone had experience of process mapping? I think this example will perhaps speak to what you were talking about, Jody, earlier. So I'm just going to ask you to think about a small general practice, right? It's got 3 doctors, including a registrar, and there's a practice nurse. They receive a letter from the emergency department about Mr. Jones. He's 69 years old, and he presented to the emergency department with sudden back pain. The diagnosis was he had a collapsed fracture of his thoracic vertebra, T5, and he's been given endo. That letter comes into the practice. What happens to it? And process mapping is a really useful way of thinking about the flow of anything within a practice. So if we were to look at the flow in this practice, it might look something like this, right? So the letter arrives, the letter's scanned, the letter's allocated. Remember, this practice had 3 GPs. So the first GP looks at the letter and he files it, and that's the end of that process. The second GP does things a bit differently, and he reviews the letter, he files the letter, but he also sends a message out to reception to say, I need to see this patient. The third GP, and let's say this is a registrar, reviews the letter, files the letter, opens the patient's record, adds the diagnosis that this patient's had a fragility fracture, requests an appointment, and ends the process there. So process mapping can really be helpful for us to sort of understand how things are happening in the practice, and we can actually break it down to look at the variation in how different people are handling the piece of paper and what they're doing with the scanned document in this case. Jody, does that sort of sound familiar to the project you described to us earlier? Thanks, Jody. The issue with this is we don't get reliability, right? Because people are doing things in a different way. You could apply this to lots of different processes within the practice to really understand the variation. One of the things we often talk about is, reliability of processes. And in engineering terms, if you were to ask engineers, they would say that a process or a product is chaotic if it fails in more than 20% of the opportunities. If you get 80 to 90% reliability, it fails more than 1 in 10 times. 95% reliability is 5 in 100 times, and 99% reliability is 1 in 100, right? So simple stats. If you ask 5 frontline users to articulate a process and they can't easily articulate it, you've probably got 80 to 90% reliability. If 5 frontline users can easily articulate the process, you've probably got 95% reliability. And to get 99% reliability, you really need everyone to be almost obsessive about the way a process works. And you can get that in a well-designed system with cooperative relationships. So to get to 99% is pretty hard. Actually, to get to 80% is quite hard in healthcare. So, and I've got another slide later on which kind of describes why that's the case. But if I were to tell you, there's been a couple of separate studies, one in the US and the second one in Australia, with the original author from the US participating in the study, which kind of said, if we look at healthcare and how often healthcare is reliably delivered across the board, then it's about 55% of the time on average that the care as described by guidelines is delivered. So again, just to bear that in mind, and that sort of study has been reproduced a lot of times, which kind of shows that healthcare reliability is generally less than 80%. So in engineering terms, it's chaotic. Just bear that thought in mind. The third tool I'd like to introduce you to is the driver diagram. So I beg your pardon. Has anyone come across driver diagrams? So yes from me, no from Janine. I find driver diagrams are a really, really useful tool because it's about getting almost your strategic plan of how you want to achieve something onto one page. And basically what a driver diagram does is it says on the left-hand side, your aim, your outcome, what you're trying to achieve. And then you've got the things that drive you towards achieving that aim. And then you can map onto that the potential change ideas or change concepts, the things you could do a PDSA on, for example, to help you with it. So if you look at this driver diagram, we got actually, this is quite a complex driver diagram because it's got both diabetes and asthma and certain targets that they're trying to achieve. Look at the key drivers and maybe just look at the top one. What they're saying is one of the key drivers is if we use a registry to manage the population, then that will help us. So we've got to identify each affected patient at every visit. We've got to identify the services needed for that patient. And we've got to have a recall system so we can follow up these patients. So change concepts are then on the right-hand side. And so this is a good way of thinking about, if you want to particularly achieve an aim, what are the different things that drive you towards that? And how do you get there? So here's another example, right? So we want to improve the care of our patients with COPD by 50% within 9 months. This is a simpler example. Well, the driver for that is the delivery of appropriate evidence-based care. There's a driver around self-management. There's a driver around staff capabilities, so making sure everyone's aware of this. And then there's a driver around accurate recording and monitoring. Let's just look at maybe enabling self-management. A secondary driver would be assessing the self-management ability of patients. If we look at the primary driver of improving delivery of appropriate evidence-based care, well, in order for us to do that, there's 3 other things, right? So we want accessibility, we want support at the point of care, and we want prevention as well. So you can then build that driver diagram further and say, well, okay, if these are all the different things that are needed for us to improve the care of our patients with COPD by 50% within 9 months, how are we going to measure this? So firstly, how are we going to know that the care of our patients with COPD has improved by 50% within 9 months? Well, we're going to do a COPD assessment test score on this patient, on every patient with COPD, and look at the improvement in that. For us to be able to improve self-management, we're going to use a validated survey tool which tells us people's ability for self-management. So we might use a patient activation measure. In this example, we're going to look at how many of our patients with COPD who had the Partners in Health Scale assessment completed. And so for each of the drivers and for each of the secondary drivers, we can start to create metrics and measurements, and then we can do PDSAs around that. So that's really another tool that I wanted to really share with you, because it's one I've personally found really, really useful. Because ultimately what we're trying to get to in a position in healthcare is move from where we are on the left, where we've got a standard of care, but the way we do that care, even within a practice, is quite variable. Different people do it different ways because they want, they want their autonomy, they want to do it their way. We often don't feed back for improvement. And the processes and the way things are done, even if you're looking at improving, are often changed by individuals. And so we get that reliability being at a fairly low level, 60 to 90%. So this comes from the Mayo Clinic in the US, this diagram. Whereas what we really want to do is move to something on the right. So we really want variation to only be based on clinical criteria, rather than because I, as a GP, think that's the way I want to do it. And then one of my colleagues thinks he wants to do it in a different way, or she wants to do it in a different way. Let's not vary it because of what she or he or I or he thinks. Let's vary it only because it's the right thing for the patient. Otherwise, we stick to a standardized process. So the autonomy to change the way we do things is taken away, it's standardized. The process becomes owned from start to finish. We can start to learn with the gaps in the processes before harm occurs. And we can constantly improve this by collective wisdom. And so that team-based approach, that quality improvement principle we talked about earlier. And then the other thing I want to share with you is, so we talked about process maps earlier. So this is a process map from actually one of the practices I used to work at before, around the diabetes risk assessment for patients. And so we've set up a process map, sort of designed as a team around how we were going to do this. And so there's some things the receptionist was going to do, and you've got that identified in that swim lane called reception. And there's some things the nurse was going to do, and you've got that identified in the swim lane on the right. So we've actually got some clarification of roles and responsibilities around who's doing what and how it all connects together. And then you can see on this flowchart that there are some numbers. You've got numbers 1 to 6. Each one of those numbers can actually be a measurement point. So we've got the measures on the right-hand side around this to see how well this process is working. We can have a bunch of process measures which will feed back to us whether this process is working or not. We can feed those numbers back to the reception and the nurses who are managing this process, and allow them to do PDSAs to tweak the process to get the improvements until we get to a point where the process is working in a really reliable way. So they're just some tools I wanted to share with you. Any questions about those? No? Okay, let's move on to thinking about, why do we reliably fail? Okay, we're going to start with a video, and some of you may have seen this video. So if you have, please play along. If you haven't, let's watch the video and see what you can, how you get on with this exercise. So in this video, you've got a bunch of people playing. They've got a ball and they're passing the ball around. Essentially, there's two teams, right? So there's a team of people with white shirts and a team of people wearing darker shirts. What I'd like you to do when you watch this video is count all the passes made by the white team. And we're going to celebrate. So it states here there's an award for the person that gets the correct answer. Well, there's a virtual award, okay? We're going to celebrate the person who gets the correct answer. Or if there's several of you, we're going to celebrate the fact that few of you have got the correct answer. So you ready? Has anyone got any questions about the task? Okay, well, I'm going to move on to the next slide and then start the video. So get ready. You're counting all the passes made by the white team. Okay, who wants to, well, if you type your numbers in, why don't you all type your numbers in the chat box and we'll see what you got. And as you're typing your numbers in, if you saw anything else, feel free to type that in as well. Okay, so we've got a range from 9 to 18. One person saw a gorilla suit. Mary? Did anyone else see a gorilla suit? No. Emma, no. Kerry, no. Serena, you've seen it before, so you knew what this was about. Wendy, yes. Jodie, no. Okay. All right, so I'm going to first of all say, well done, Wendy. The correct answer is 18. Okay, so point number one from this video is this is a pretty simple task, right? We can all count. It was a fairly simple task. It was clear instructions, I hope. Yet we've got a variation in the response. Yeah. The reason we get that variation is because of human factors. Kerry, you talked about getting a bit dizzy towards the end and you got to 17. We've got to realize that in healthcare, we're going to have the same variation when we're measuring spirometries, when we're reading ECGs, when we're checking blood pressures, when we're doing BGLs. So hence Deming's issue around, we've got to understand variation. The more important thing about this video is you all missed, well, not all, a couple of you saw the gorilla suit, but many of you missed the gorilla. Okay, and I'm going to play it again, and I'm going to pause when the gorilla comes in, and I promise you, this is exactly the same video. I haven't moved slides to change the video. And so let's just pause there. And right in the middle of those people is a man wearing a gorilla suit, or a lady wearing a gorilla suit, walking across, beating his or her chest, and then, if you carry on with the video, walks out. And when you look at that, those of you who didn't see it the first time, you'll be thinking to yourself, how on earth did I miss that? It's so damn obvious. You missed it because it's human factors, right? You missed it because you were focused on a task, and you were so focused on the task that you missed something blindingly obvious that was in front of you. Okay. And that's one of the reasons quality improvement is so hard. Okay. It's one of the reasons we only get 50, I said 55% earlier, it's 57%. It's one of the reasons appropriate care is only received in 57% of eligible healthcare encounters, right? Because when you think about our care delivery is a set of processes, right? It's a set of steps we do. Okay, if we want to get 90% reliability in those steps, then each one of the steps we have has to have a much higher level of reliability. So for example, if we've got a process with 4 steps in it, each one of those steps has to be done accurately, 97.5%, to collectively get a 90% reliability. If you just think back to that diabetes risk assessment flowchart I showed you, that process map, with the number of steps in that, there were way more than 4 steps there. If we wanted to get 90% of our patients who are eligible to have a diabetes risk assessment done, we would have needed to have close to 99+% reliability in each one of those steps in the process. That's why quality improvement is so hard, because you've got the human factors issues, you've got the issues around designing processes and needing high reliability in each step. I talked about the root cause analysis earlier, and I said I'd share with you some thinking about a slight variation of that, which I really like, and that's what this is. So this is really thinking about a systems approach from somebody called Charles Vincent at Imperial College London, and he developed what's become known as the London Protocol. And again, this is around analyzing adverse events. But actually, what you can do is, instead of the adverse event, you can put in there any sort of improvement thing that you're trying to do, and look at the factors that contribute to that improvement. And often what we do is we just focus on the care delivery problem, right? So we talk about errors, or we talk about violations. So I'll explain violations in a bit in the next sort of set of slides. And we try and design our interventions around that. But actually, those active failures, me forgetting to code somebody with diabetes, me not doing the coding when a letter comes in with somebody with fragility fracture, I may know to do that, but there's a whole bunch of reasons I might not do that. Okay. Those contributing factors may be related to the work environment, they may be related to team factors, they may be related to personal factors, they may be related to task factors, they may be related to patient factors, right? So if I just look at, for example, that letter coming in about Mr. Jones, who had the vertebral collapse fracture, I might be that GP registrar at the end who does the perfect steps, okay? But sometimes I'll be tired and forget to do that. Sometimes I might just be running late and forget to do that. Sometimes the computer might be being really, really slow, that I decide to not open up the record because it's just slowing me down too much. And therefore the task factor, it becomes an issue. Sometimes the receptionist might scan that on and file it straight into the notes in error because they're busy or they were distracted when they were doing it, rather than assigning it to my workflow. It might be a really complex patient who, yes, went in for their collapsed vertebra fracture, but also had 10 other things. The letter's got a lot of noise on it, and I don't just pick up on the fact that there's a new diagnosis there. So it's a whole bunch of contributing conditions we need to think about. And if we understand and do that root cause analysis to identify some of those contributing factors and design our quality improvement around that, we're more likely to get success that's sustainable. However, it doesn't stop there, right? Because it depends on organizational and cultural issues. It depends on, how focused your leadership is on quality, whether there's any perverse factors that are at play. It depends on your sort of health system context. Depends on whether you've invested in technology or not, whether you've invested in quality improvement or not. A lot of these are organizational and cultural issues. Even if you get all of that right, sometimes things go wrong. And so there's a concept around, we need to put in place barriers and defenses. So even if we do the wrong thing, they're identified before they become a problem. So in the context of data cleansing and getting the data right, I often talk about housekeeping searches. So let's say we're looking at atrial fibrillation. And we want to see whether we've got recorded all our patients with atrial fibrillation as having atrial fibrillation. We can do a housekeeping search every so often to say, how many patients have we got on digoxin, which is often only used for a couple of things. It's often only used for atrial fibrillation. Sometimes it's used for people with heart failure who haven't got atrial fibrillation. Often it's really only used for atrial fibrillation. So you could do a housekeeping search and say, look, of all our patients on digoxin, how many haven't got atrial fibrillation as a diagnosis? And you could do that every 3 months or every 2 months, whatever you deem appropriate. And you might identify 1 or 2 people where the diagnosis, the coding has been missed, and correct that. And you could do that for a whole bunch of things, right? That's an example of a barrier or defense, a procedural element you've put in to identify the fact that something should be happening and it's not, but you've caught it before it becomes an error in care. On that diagram was also violations. And so what I'm going to do is just talk about violations. And then we're going to move on to talk about the model for improvement and the PIP QI in the last sort of 20 minutes of today. Before I talk about violations and migrations, which is another sort of concept, really want to get over to you. Has anyone got any questions? Because I'm mindful that we've talked about quite a lot there, and some of it may well be new to a lot of you. So I just want to pause and see if there's any questions. Okay, thanks, Simon. All good from you. Anyone else? You happy for me to move on? Okay, let's move on. Thanks, Lisa. So, violations and migrations are another component of, I think, what we need to think about, okay? So we started this off and we said we have policies and procedures, and we have policies and procedures for a lot of things, right? But in that example at the beginning from Serena, Serena very eloquently articulated how there's a compliance check that's done regularly as well as part of that policies and procedures control mechanism. Okay, that's not always done, you know. So often I see that we have policies and procedures manuals and they kind of sit on the shelf and not really utilized after that. So it's great that you've got examples of some living documents. I'm going to just use driving as an example to take you through this concept, and then we'll sort of see how it applies to healthcare. But, you know, we have speed limits, right, in driving. So let's say the speed limit of the road we're driving on is 60 kilometers per hour, and that's a legal space. That's a policy and procedure equivalent. Okay? We shouldn't go more than 60 kilometers per hour. If we were face to face, I'd ask for a show of hands to say, how many of you regularly in a 60 kilometer zone might go a bit higher? Might do that 62, 63, 65 kilometers? Okay. We often, knowing that 60 kilometers is the legal space, go a little bit faster, don't we? And maybe a whole bunch of reasons. It might be life pressures, you know, we are late leaving for work today, got to get there. I'll just go a bit faster. It's okay. 65 is going to be fine. Yeah. I've got a pretty good car. It's safe. You know, it's got airbags on it. It's got anti-skid braking system on it. You know, it's really safe. So my perceived vulnerability is pretty low. You know, and it's a pretty quiet road. There's very few people on it in my way to work. You know, nothing's going to happen. 65 is going to be fine. So I've got a belief system that kind of makes me think it's fine, you know. So I'll push the boundary, okay, and I'll drive in that slightly above the legal space, okay. And I'm not the only one who does that. A lot of people do that. So it's interesting. On my way to work on Tuesday this week, I go on a dual carriageway, and I wasn't late. I was running on time, so I was actually going a little bit under the speed limit, but not that much under. You know, it's the 80 kilometer zone, and I was being at 78, 79, and the number of cars that came up behind me and overtook me, not going very fast. They were probably going 5-10 kilometers per hour over the legal space there. Okay, so you know, the number of people that drive in this illegal normal space, just slightly above, is quite high. Okay, the reason is because we get some benefit from it. We get somewhere a little bit quicker. Sometimes our performance is sort of better as a result as well. Okay, and then we've got these other things that drive us: the life pressures, the belief system, the perceived vulnerability, and so we drive there. Very few of us are going to go into this 95 kilometer speed limit, all right, when we're in a 60 kilometer zone. That's the illegal space. Majority of us aren't going to go there. Okay. The exception may be when there's a real emergency that you've got to get there. So let's say someone really unwell in your car, and you've got to, you know, you've just got to get to hospital, and you might push the speed limit then. But generally speaking, you're not going to do that for the majority of us. There may be the occasion ones that do. So here we've got a system where we've got a speed limit. We all know the legal space. Most of us may operate on the fringes of that legal space, okay? And there's a little bit of system migration. We actually know that police camera checks are unlikely to find us at 62, 64 kilometers per hour. You know, the sensitivity of speed cameras has got an error margin in that. So there's a little bit of an allowance for that. But if we have an accident, we often go back to that legal space, don't we? We become really slow. And then as things sort of settle down and go further away from that time, we migrate again. So we have a system that operates at 60 kilometers per hour, but it's often migrated. So it's not uncommon for the illegal normal space to be the norm. When we're thinking about policies and procedures and regulation, that's often what happens, right? So we have policies and procedures defined by professional standards. We have, you know, the Red Book of Preventative Healthcare. We have all the research papers that have told us that, you know, we need to be anticoagulating people with atrial fibrillation and do a CHAD score on them, and we should be doing a osteoporosis, a fracture risk score on people with osteoporosis, and we should be making sure all our patients with ischemic heart disease get smoking cessation advice if they're smokers, and have their cholesterol checked so often, and have their cholesterol to a certain target. And, you know, there's a whole bunch of policies, procedures, professional standards, all driven by often very good evidence. Yet, for various reasons, most of us operate in this usual space of action, right? Whether that's us as healthcare professionals or people working in the health system, or whether it's us as patients. I won't take my statin today. I won't do this. I won't do that. And there's various reasons for that. So policies and procedures often, whilst well-intentioned, aren't followed in a reliable way, and they should build in a quality control system, like we heard about earlier. Take hand washing as an example, and I actually think we've done really good in healthcare now with this. You know, I should wash my hands between every patient. The system migration is I wash my hands when I remember, or for aseptic technique. And then there's sometimes a belief that I didn't actually touch that patient, so I don't really need to wash my hands. And so you can see how a simple policy can get system migration based on individual beliefs and perceived vulnerabilities and sort of life pressures, and, you know, wanting to get on with things and get them done. So when we're thinking about health system performance, we need to think about it in broader terms. We need to think about it in terms of human factors, productivity, and reliability of design. We've touched on a lot of these things, but when we're really thinking about this sort of violations and migrations, most of the time we're working in this space, which is called a borderline tolerated condition of use, somewhere in the illegal normal space. That's often not appreciated or recognized. It's often the sort of stabilized usual level of performance, and though it lies outside that safe space as defined by policy, procedure, regulations, it becomes a place where adverse events are pretty rare, and we start to feel comfortable in that spot. It's often seen as a benefit to be working in that space because it saves time, increases our productivity, and so we get a tension between following protocol and productivity. The consequence of that, though, is over time, you get a large range of, in quotes, illegal practices, which becomes normalized. We all have a role in thinking about how we, A, identify where we're operating, that borderline tolerated condition of use, but also what we do about it. So I'm going to skip the next 2 or 3 slides and really talk about how you manage migrations. So there's a number of ways we can approach this. Okay. One of the things is to have conversations early on, so you develop that collective experience of incidents and share stories, and you agree to sort of stop the migration. So that dialogic approach, which was mentioned at the beginning, is useful. And as a result of that, you might actually accept and adapt the protocols and defenses and vary it slightly. The second step is you acknowledge that individual variation in risk acceptance happens, but in order to deal with that, you need a system response. So you look at the human factors behind it, and you try and suppress those triggering conditions and try and build in those human factors into the reliability. Where people are going into that forbidden space, the very unsafe space, that's where it's absolutely appropriate to take a hardline approach and a sort of performance management approach to those things, because they just shouldn't happen, that very unsafe space, without extremely good reason. But for the other space, it's a focus on human factors. And what we know from human factors research is errors are common, they're predictable, we know the causes of errors. They're actually a useful byproduct of our cognitive functions. And many of them happen because we rely on short-term memory or attention span. So go back to that basketball video and missing the gorilla. And I think, Emma, I think your comment about concentrating too much on the task at hand, you lose the sort of situational awareness around it. So that's a real good example of, human factors at play. When a clinician's sort of dealing with a patient, there's a bit of a complex problem, and they're reasoning to work out what's going on with this patient. The last thing on their mind, even they know that they need to do it, is perhaps to check the weight, ask them about the allergy, or put the blood pressure in the right box. So what we really need to do is recognize that whatever processes we put in place, there's going to be some failure that occurs. And so we need to just put in place some steps that identify that, capture it, and feed back to that. And the common sorts of things you can put in are sort of human systems, physical, functional, symbolic, or procedural culture things. So, and you've got some examples on the right-hand side here. So this is in your workbooks, and I'm not going to go into depth because of time in this particular for this particular component, but just wanted to give you a sense that it's important to look at this and think about barrier systems and what you can do there. And so there's some examples for you to think about that. So when we're thinking about designing quality and safety solutions, what we really want to do is make it easy to do the right thing. That's our default position. We want to design tasks so they don't depend on attention span, because you've seen from that short video about the basketball and the gorilla that it's easy to miss something glaringly obvious. If we're fatigued, then that makes it worse. So we want to really, in our processes, think about avoiding fatigue. We want to try and keep tasks as simple as possible. Same with protocols and equipment. We want to standardize things, because if we standardize it, then we all know how it should be done by us and by others as well. We want to use protocols and checklists, but wisely, because too many of those things, too many prompts on your computer system reminding you to do A, B, and C, and what happens is people ignore them. So we want to get the balance right between using protocols and checklists and use them wisely. We often resort to training and education and retraining. And in my experience, training and education is necessary, but never sufficient. So yes, we've got to do it, but it's not enough. So we've got to really think about all the other things. And that's where the model for improvement kind of comes in. I think last week I shared with you this slide. The model for improvement about trying to deal with those bumps, but not once every 3 months. If we get the culture right, we want to be doing this. It's everyone's job every day, right? So we want to, every time we identify a bump, let's look at how we can solve the bump. The usual approach to quality improvement is we go into a meeting room where we think hard about it, and we design and design and design, and we approve a new way of doing things, and we implement. And what we're really saying with the model for improvement is we don't want to be doing that. Instead, what we want to be doing is having an idea, testing it, refining it, testing it, refining it, maybe going back to a meeting room, rethinking it, put it back out in the workplace, test, refine, maybe go back to design, come back out. But this kind of iterative learning, the knowledge of the system in Deming's terms, is what we want to be doing. And the way to do that is using the model for improvement, is using PDSAs. So by the time we get to implementation, we've got a lot of confidence that whatever we're putting out there is going to work. And we've got a lot of engagement. I think I shared this slide with you last week as well, that when we're trying to change something, there's a whole series of processes that we need to think about. And if we get those right, we get change. If we don't get those right, we get a lot of other things, including false starts and anxiety and confusion. So we really need to think about not missing out on any of those steps so we can get the desired change we want. The model for improvement I want to introduce to you today, we're going to think about the fidelity with which we do the model for improvement next week. But the model for improvement is really a two-step part. It's really a two-step process. There's a thinking part, and the thinking part says, what are we trying to accomplish? So that bigger aim, the goal, it could be the left-hand side of your driver diagram. How will we know that a change is an improvement? So that's the measurement piece. And we're going to talk a lot more about measurement next week. But, go back to what I said earlier around knowledge of variation that Deming talked about. If we can't measure something, we can't really improve it. So measurement is an important part of question 2. And then what are the changes that we can make that will result in improvement? That's the rest of your driver diagram. It's all those changes related to all the drivers on the right-hand side that collectively will come together to help you achieve the aim on that left-hand side of the driver diagram. All those changes are just ideas. They're not necessarily going to work, okay? But what we want to do is develop knowledge of our system, and therefore we want to test them in practice to see how our system, how the people, the processes we put in place to do this improvement, to carry out this idea, how they react to the idea, and we learn from that. And that's where the PDSA comes in. So it's about planning a test of change, when we're planning that test, we really want to think about having a hypothesis around what this test is going to achieve, have a prediction around what we want this, what we think will happen as a result of this, develop a plan for testing the change, and it's got to be small. You know, who's going to do it? When are they going to do it? What are we going to? What metrics are we going to use to understand whether this test has worked or not? When are we going to review it and study it? And then we try out that test on a small scale. I want you to really take away the small scale concept of this, and we'll come back to that next week when we talk about the fidelity of the PDSA. You review the learning from the doing part, and then you act on that learning to plan your next test. And so in that sort of way, you test out the ideas you think will help improve the drivers. The drivers will then improve and get you to your aim. This is a paper written by Paul Plesek as one of the authors, who's now a prof at Bond University in Queensland. And it's written a while back, so back in 2005, and Paul and his co-author said that, you know, we've got all this research, we've got all this evidence represented by the triangle on the left-hand side. But if you want to get all that research and all that evidence into practice to have a happy patient at the end, there's a whole bunch of things we need to go through. We need to know about that evidence and have that evidence available to us at point of care. We need to be able to act on that evidence and see its applicability, and that's where the CQI part comes in. And we need to, you know, patients need to agree to it and adhere to it as well. So that's where the patient-centered aspect of this comes in. Patient education material, the shared decision-making tools, and so on. So this is pretty complex stuff, but it's all doable. And I guess where we are now in Australia is, you know, quality's obviously been on the cards for a while. But if you go back to what we talked about last week and why this is all important, where we're landing now is we've got an incentive called the Practice Incentive Program, Quality Improvement. And this is really a payment that will come to practices to support practices in doing continuous quality improvement. And there's really two parts to it. You know, there's a part around having an agreed data set, minimum data set, that we provide back to the PHN. And there's some operational issues around that, which I'm sure you're all aware of, but we can touch on those and talk about those. There's within that 10 indicators at the moment around that minimum data set as to what needs to go back. The second component is that practices will engage in quality improvement. That quality improvement can be around those 10 indicators, or it can be something else more relevant to the practice, but informed by its own analysis and needs that it's identified. The 10 components within the QI indicators are listed on this slide. And you'll see there's some around sort of demographic stuff, like, well, you know, things like smoking and allergy and weights. There's some stuff around prevention, so influenza and the different categories of patients who would benefit from influenza. There's some stuff around screening, so cardiovascular risk assessment, cervical screening, and then some stuff around diabetes and getting the evidence-based care into diabetes. So when you actually look at that, a lot of those are process indicators. And perhaps just bear that in mind, because we may well come back to that next week. In terms of sharing the data, there will have been some operational issues. So the idea was at the beginning that there would be a data extract from practices' clinical information systems that would be anonymized and de-identified, and just the 10 indicators would be pulled out and they'd go into a data warehouse hosted by the PHN, and then that will be aggregated further and go to AIHW, so the whole system can kind of learn from it. There were some very challenging operational issues around that, so not all clinical systems could do the data extraction. So the Department of Health put in place some interim measures to support the practices who had systems that weren't compliant with this. We're at the point in time, sort of just over a year after this PIP was implemented, that a solution's been found. And so my understanding is that the solution's been found for pretty much all practices. There may be a few practices for whom it still doesn't work. And for those practices, they should have notified the Department of Health by yesterday. But there's a sort of additional piece of software which will allow a push function for data to be sent to the PHN and subsequently AIHW. This slide sort of summarizes the QI requirements. I've actually talked through, I think, most of what's on this slide. Just perusing it to make sure that I haven't missed anything on there. I don't think I have. I think we've covered most of what's on here. There's some technical bits around the information that goes to the department and the compliance checks and the monetary values, which I haven't talked about. But otherwise, I think we've talked about the PIP QI. The PHN has, of course, also got a data quality program, which many of you, I'm guessing, will be aware of. And as part of that, it gives practices free access to the CAT Plus suite of clinical audit tools. So that these are software solutions to help you extract data, so you can build in that learning we talked about earlier. And you probably know better than I do around what the programs are available to you are, but there is a program around general practice diabetes and obesity, CQI.
Excuse me, sorry. Can I just ask a question? It's Serena. Can you go back one slide there, please? Yeah.
This one?
Yeah, that's it. So the NQ-PHN provides all general practices with free access to CAT Plus suite of clinical audit tools. So does that mean that the PHN will then have access to, if we use that, to other things other than those 10 clinical indicators from our software?
Yes, so I think it depends, and this is a question for the PHN, and I'm happy to...
Hi, Paresh, it's Janine
Hi.
from the PHN. How are you?
Good.
Serena, yeah, that's fine. You can absolutely use your CAT4 software to do any quality improvement activity outside of those 10 measures. You are not restricted to in the use of that. That's just your software tool for your practice for that 12 months.
Okay, and will the PHN be able to see what we're doing?
If you're part of the data program, we extract de-identified data on a monthly basis.
Yeah, that's those 10 ones that were listed before. So is the PHN extracting more than those 10 item numbers now?
The way that the program is set up now is you can choose to extract, you can choose to just extract the 10 measures and give us the de-identified data for just the 10 measures.
Yeah.
And for that, we don't provide the CAT4 suite. But if you are part of the data program in its entirety, you get access to the CAT4 suite and top bar. And we also provide monthly reports back to your practice.
Okay, so that's yes then.
Data. Yes.
Yeah.
Yep.
Okay, so currently the PHN, so just let me get this straight, because maybe my manager does all this. If we only agree to give the PHN those 10 things,
yes,
can't get the CAT4 plus?
You can get CAT4 plus, we just won't, it won't be something that the PHN fund.
Gotcha.
Yeah, so yeah, just ask, what practice are you from, Serena?
Abbott Medical.
Okay. I can have a look and see if you are part of that program.
Yeah. Okay, thank you.
No problem.
So at a high level, probably the important differentiation here is there's the PIP QI, which is the 10 indicators which go to the PHN. The PIP QI eligibility requirements only require to provide those 10 indicators. Many PHNs around the country, including Northern Queensland, also offer practices a more comprehensive data initiative and a quality improvement initiative, which is broader than the QI PIP and in some ways separate from the QI PIP. And so that often includes data extraction tools and quality improvement support. And so with QI PIP coming in, PIP QI coming in, you know, there's become an overlap which is causing confusion. But you know, it's perhaps best to think about the two as separate programs, but with a little bit of overlap. The eligibility will be different. What's offered will be different. There's also a question, I think from you, Serena, around putting the numbers in a spreadsheet to the PHN. Now, my understanding is now, as of this quarter, it has to go through, so PenCS as the sort of tool most PHNs are using to aggregate their data, have introduced a functionality where you can upload a file to it, but it needs to be in a compatible format. So you can't just put it on a spreadsheet and send it. All the clinical software systems are meant to have a push function which creates a compatible format for you to then transfer that data to the PHN in a secure electronic way that's only got the anonymized information for the 10 indicators there. So looking at the CQI projects, so we talked about the diabetes and obesity intervention there. There is a new one, I understand, the PHN's rolling out, which is cancer screening and primary care initiative and tool. And I think that will be coming shortly. There's also the support around digital health. So My Health Record Pathology uploads. And Janine's just said, thanks, Janine, and My Health for Life, and that you're happy to share those resources. Here's a high-level overview of the cancer screening CQI program that will be rolled out by the PHN. And so this is really just to give you a heads up about this. And within that, there will be a work plan or a couple of plans that will help support you as practices to improve your data. And so there's some, and you can see there's a sort of matrix here with the timeline and various steps you need to do to be able to improve and achieve the goal you set for yourself. And the goal you set for yourself needs to be a SMART goal, so specific, measurable, attainable, realistic, and timely goal. Some of these things around SMART goals we cover next week in the how. Here's the matrix which kind of talks about the progress along those interventions. So we have got to the end of today's webinar. We've covered an enormous amount of material. If we look at what we've done today, we really talked about quality management systems. We've touched on the model for improvement, but we're going to go into the fidelity of the model for improvement next week. And we've looked at the PIP QI and how you can start to think about the PIP QI through some of those PHN resources that are available to you. Next week, we're going to move on to the how, and really we're going to focus on the authentic PDSA and the measurement for improvement. So how you use those tools with the fidelity with which they were designed. I'm just going to remind you of the what, so what, now what. Please think about the so what, particularly as related to the PIP QI, because that's probably front of mind for many people. And with that, we'll finish today. In terms of next week, you will see in your workbooks a activity you may want to consider doing. I call this the mirror activity. So the idea is perhaps look at a self-assessment of where you are with data and quality improvement in your practices. There's some statements here which talk about measures or indicators at a practice level of quality improvement and data-driven improvement. And what I say, you can do this in various ways. For each one of these statements, you can score yourself on a 1 to 10 as to where you are. What I find is a fun way of doing it is putting these statements on a wall in the room, giving every member of your team 3 red dots and 3 green dots. The green dots are where they feel the strengths are. The red dots are where they feel the weaknesses are. And literally, when they're having a coffee in the morning or lunch, going around the staff room, give that to them and ask them to distribute their green dots and their red dots on what they think the strengths and areas for improvement for the practice are. And that's a nice, engaging way of getting everyone on board with the initiative. And then you can share that information back with them around what the strengths and areas of improvement for the practice are, and sort of convert that into a plan for improvement. So that resource has been shared with you in the workbooks and additional resources section. Encourage you to have a look at it, and if you've got time to have a go with that before next week, that'd be great. With that, if I can thank you for your time. It's been wonderful. I'm sorry we've overrun a few minutes. There's a lot of content there. Any questions, please bring them next week, and I'll be more than happy to address those. Any queries, feel free to go back to the contact details here. Have a wonderful